Nerve compression syndrome by Caleb Deaver. Median nerve. The median nerve originates from the lateral and medial cords of the brachial plexus and has contributions from ventral roots of C5, 6, 7, 8, and T1. The median nerve is the only nerve that passes through the carpal tunnel, which relates to carpal tunnel syndrome, which will not be covered in this presentation. Innervations. The median nerve, obviously, as you can see here, has a lot of muscle innervations. It's highly related to finger and hand mobility, as well as some forearm mobility. You can see here that it is very, very highly innervated with muscles, as well as innervates cutaneously, which, as you can see, there's a lot of sensory innervations, which is cutaneous innervations, which creates sensation, obviously. Anatomy. Anterior interosseous nerve. Branch of the median nerve that supplies the deep muscles on the anterior aspect of the forearm. Remember, this is an anatomical position, except the ulnar half of the flexor digitorum profundus. Its nerve roots come from C8 as well as T1. You can see on my figure where it runs. The motor innervations for this nerve is flexor pollicis longus, the index and long fingers of the flexor digitorum profundus, and the pronator quadratus. Just a few motor innervations. There is no sensory innervations for this nerve, cutaneously anyway. Anatomy. Radial nerve. It originates from the brachial plexus, as well as carrying fibers from the ventral roots of spinal nerves C5, 6, 7, 8, as well as T1. The radial nerve and its branches provide motor innervation to the dorsal arm muscles and the extrinsic extensors of the wrist as well as the hand. As we talked about before on the previous slide, you can see these motor innervations more detailed. So a lot of motor innervation as well with this nerve, as well as cutaneous sensory innervations as well. Cutaneous means on the skin, hence why you can feel it. Just a few sensory innervations. Anatomy. Posterior interosseous nerve, and it is the continuation of the deep branch of the radial nerve. It supplies muscles on the radial side as well as the dorsal side of the forearm. The nerve fibers originate C5, C7, and 8. I apologize. Quite a few motor innervations as well. Has a lot to do with the forearm. A lot of extensors, a lot of supinators and extenders. Yep. And no sensory innervations, though, as well as no cutaneous sensory innervations. Sorry. Pathology. Forearm compartment syndrome is bleeding or edema that leads to increased pressure within the fascial compartment and compromises circulation within that space as well as function of the tissue in that area. As you can see by my figure, it is quite gross. Basically, it's just swelling in that compartment of fascia, and the fascia traps in that swelling and cannot be alleviated regularly. Usually preceded by a fracture or some sort of very traumatic event. Fun story, I almost had compartment syndrome in my left forearm when I broke it. They were very worried about that. Yeah, just a nasty, nasty injury. Very hardly chronic, maybe reoccurring, but not chronic. Very acute and from very traumatic MOIs. Pathology, forearm compartment syndrome usually has a linear progression of acute sensory changes development after 30 minutes, acute irreversible nerve damage in 12 to 24 hours, acute irreversible muscle changes, necrosis, in 3 to 8 hours. So obviously a very, 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 very important injury to pay attention to. Very obvious development. As you can see, there's very obvious deformity. You need to get this person to the hospital as soon as possible. There is the potential to lose a whole limb and possibly a life if it goes necrotic and kills off tissue and can lead to infection. It's just not a good thing to piddle around with or see if you can fix, because you can't. Very, very serious. Mechanism of injury. As I said before, it is very traumatic. I know there's a lot of non-traumatic that I listed, but it is very rare to see non-traumatic in an athlete. Repetitive angiographies, repetitive x-rays, which I thought was very interesting. Injection of illicit drugs, it is still acute, but not traumatic. And hematoma in patients treated with blood thinners, you'll see that more in older population, not so much as what we would have. So, it's just something to keep in mind. Signs and symptoms include pain in the forearm, swelling, tightness of forearm muscles, relief of discomfort with rest, which is kind of alarming because a lot of other conditions are relieved with rest. But as I said, it's not very alarming in the fact that it's obvious. It's not a maybe they have it, maybe they don't know. You know they have it. It's very obvious and very deformed and gross. As you can see with this figure to the right here, that's after. You can see the tissue is still damaged even after invasive surgery. So the major one is obviously the pain, deformity, and the numbness. Predisposing factors: contact sports, extreme sports, blood thinners, and a history of compartment syndrome in that forearm. Like I said, there's not really anything that really predisposes you to it. It can happen in a car accident. There's no really way to prevent it if it's going to happen. Contact sports, extreme sports, as you can see, this guy in this figure is crazy. And yeah, so don't do anything stupid is the best way to prevent it. But in all, it's just going to happen if it's going to happen. Recognition and differential diagnosis. Recognition, very, very obvious. Differential diagnosis, cellulitis. But even then, we would still refer out for cellulitis, severe cellulitis, and compartment syndrome, obviously. So, moving on to radial tunnel syndrome. Pathology. It occurs when the radial nerve that runs beside the bones and muscle of the forearm and elbow becomes compressed. Increased pressure on the radial nerve can cause pain in the lateral aspect of the elbow and down the forearm into the hand. It can also result in a tingling sensation in the forearm as well as the hand. Mechanism of injury. Repetitive forceful motion such as pushing or pulling or twisting of the hand. What I think is very interesting is sleeping wrong can predispose you to this. I know a guy, World's Strongest Man winner Brian Shaw, had this occur and it almost ended his career. But how they treated it was they just fixed how he slept, and that resolved the issues that he had. It almost ruined his career. He couldn't grip anything anymore. So, yeah, can turn serious, but easily treatable. Signs and symptoms. Pain that worsens with rotating the wrist, outer elbow tenderness, decreased ability to grip, loss of strength in the forearm, wrist, and hand, difficulty extending the wrist as well. A few special tests we're going to run through here is the pinch grip test, used to examine the neurological dysfunction of the anterior interosseous nerve branch of the median nerve. Pretty self-explanatory. I have a few technique tips here, but I mean, you're just pinching and seeing if that person can pinch. As well as a variation of this, you try to separate their fingers to test their strength, which you should do in manual muscle testing anyway. Tunnel sign. Commonly used to diagnose carpal tunnel syndrome. However, the test can also be used to test for other nerve conditions as well. You can see a few of those conditions right here, which is also being covered by other students. I put in a video, but I thought this picture was explanatory enough. You hold out their arm and then tap where the nerve goes through and see if there's any sort of tenderness or if they're getting any radiating pain or numbness. Oh, wow. Flexor test. Should be done with the manual muscle testing part of the eval. You're just flexing the wrist, both resistive and passively, as well as actively. So pretty self-explanatory there. I apologize for the image being over the words, but in this case, the image is more important than the words anyway. Special test continued. Pronator teres test. Once again, you can go in a handshake position and work on extension, flexion, as well as pronation. And you're just going through those range of motion testing the pronator teres. So, yeah, there's a little few technique tips on the slide as well. Predisposing factors. As we touched on already, having an office job, offensive and defensive linemen have this because forceful pushing and pulling is their whole MO of what they're doing. Incorrect sleeping technique, which is what we already covered, construction as well as factory workers. So a lot of overuse. Recognition and differential diagnosis. Lateral epicondylitis and cervical radiocopathy at C6 as well as C7. That's just a few. Lateral epicondylitis, I would say, as well as some pronator teres pain could also be thrown in there. But as far as recognition, we kind of already went through that with weakness and things as well. So management and treatment for both of these, these would work more with the tunnel syndrome more than anterior compartment. These would be rest, ice, and heat, physical therapy, NSAIDs, steroid injections, ultimately surgery on anterior compartment, maybe on radial tunnel if necessary. Most of these things are just going to be managing the pain associated with these injuries and syndromes, but most of this is just treating the pain. Referral and immobilization. Obviously, an immediate referral to a physician should be made with both conditions, considering they're both nerve related, but one should be done before the other, and that is obviously anterior compartment, and that should be on site. Immediately from the recognition of that compartment syndrome developing, it's most likely going to be with a fracture, so they're going to be going to the emergency room. But with anterior compartment, I would almost squad them because they can lose a limb fairly quickly, and you don't want them waiting in line. So, do what you think is necessary, but obviously refer immediately for anterior compartment. Prevention. Avoid overuse, practice good sleeping habits, learn to fall, and avoid obvious danger. That's just sleeping correctly for radial tunnel and using good mechanics when you're working out and or working, I should say, and just have common sense, really. And if as far as anterior compartment, there's no way to prevent it. Like I said, it's very traumatic, so it's really just luck of the draw. Obviously, no Mulligan technique, and obviously no nerve glides due to the seriousness of both of these. There's no good way to treat besides managing pain and eventually surgery if you can't manage that pain well enough. Here's my Peacock, and here are my references. No.coms. And that is all. Thank you for watching the video, and hopefully you learned something. We'll see you.